the vertigo management. The management of dizziness and vertigo, the available treatment options are shown in this flow chart. The drugs for non-specific symptomatic therapy, mainly vertigo suppression drugs, specific therapy to treat the underlying disorder, maneuvers for BPPV, physical therapy, non-specific vestibular exercises like Cawthorne-Cooksey exercises, Tai Chi, yoga, virtual reality, organ-specific vestibular physiotherapy. My talk will be limited to these two things: non-specific symptomatic therapy, specific therapy to treat the underlying disorder, maneuvers for BPPV, and something on the time-tested Cawthorne-Cooksey exercises. So, outline of my talk: the drugs for specific disorders, for vertigo suppression, and treatment of BPPV with repositioning maneuvers and physical therapy. So, the drug classes which are used are anticonvulsants like carbamazepine, oxcarbazepine, and lacosamide for vestibular epilepsy, tornadoes epilepsy. The rare forms: vestibular paroxysmia, the neurovascular cross-compression syndrome of the 8th cranial nerve, other central vestibular paroxysmia, and myokemia of the superior oblique muscle, a rare disease entity. Antivertiginous drugs, or you can say the vestibular suppressant drugs, are to be used for a short period of time, for 3 to 5 days, because they delay the central compensation. They are mainly for symptoms of nausea and vomiting, that is the vegetative symptoms in case of acute vestibulopathy, which may be due to involvement of a central lesion or a peripheral lesion, or central positional vomiting, or severe attacks with vomiting after the liberatory maneuver in BPPV. Sometimes they are used for the prevention of motion sickness. Beta adrenoreceptor blockers for basilar and vestibular migraine. Beta-histine with or without selgiline for Meniere's disease, prevention of attacks. Corticosteroids for acute vestibular neuritis for short-term relief. Ototoxic antibiotics, especially the local intratympanic use, is for the Meniere's disease and vestibular drop attacks. Acetazolamide and 4-aminopyridine are used in familial episodial ataxia type 2. The baclofen, 3,4-diaminopyridine and 4-aminopyridine are used to treat the symptomatic oscillopsia due to downbeat nystagmus, and sometimes it may be useful in upbeat nystagmus also. These two compounds, 3,4-diaminopyridine and 4-aminopyridine, are not available in India. Selective serotonin reuptake inhibitors are used in persistent postural perceptual dizziness, triple PD, along with the cognitive behavioral therapy. The liberatory maneuvers or the positional maneuvers are used for benign paroxysmal positional vertigo due to canalolithiasis. The physical therapy or the mechanical therapy is used for the BPPV due to cupulolithiasis. The vestibular exercises, or which we usually give by the tear-away sheets, they are for the improvement of the central vestibular composition of a vestibular tonus imbalance, that is acute unilateral vestibular loss due to acute vestibular neuritis, or habituation to prevent the motion sickness. These are some of the drugs like scopolamine transdermal patch, which is used as a muscarinic antagonist in the motion sickness, seasickness, and sometimes postoperatively to prevent nausea and vomiting. Beware of its anticholinergic effects, which could lead to detention, blurring of vision, and dryness of mouth. The antihistamines like dimenhydrinate and maclizine, which are commonly used histamine H1 antagonists, are used for short-term control of vegetative symptoms like vomiting and vertigo for maximum of 3 to 5 days. Benzodiazepines like diazepam and clonazepam, which are GABA agonists, are also useful for the short-term control of vertigo. About beta-histine, much has been said for and against the beta-histine. My take is that there are studies, a meta-analysis which was published in year 2006 confirms the therapeutic benefit and usefulness of beta-histine in cupulocanalolithiasis and in those forms secondary to the vertebrophysical arterial deficits, regardless of the specific cause of the deficit itself. In controlled clinical trials, the beta-histine given orally was found to be more effective than placebo than other drugs in improving the symptoms related to Meniere's disease such as vertigo sensation and usual dose is 24 to 48 milligrams per day, administered in 2 to 3 divided doses. This is according to this Michael Lacour's paper in 2001. So the final part, which is my major part of the talk, is treatment of BPPV, which is the most common cause of vertigo as narrated by Professor Shekhar. So what is done in the diagnostic positional test during the management? The head and body of the patient are oriented in a manner that there is an ampulofugal or ampulopetrocupular deflection of the involved semicircular canal, and this generates the oculomotor patterns in accordance with the Vats law, and that is important for the localization and lateralization of the involved canal. Without that, it is not possible to treat the BPPV with maneuvers. Julius Ivan, around 150 years ago, in his experiment in pigeons, framed the law that bear his name. He cannulated each of the 3 semicircular canals and applied positive and negative pressure to observe the intensity and direction of the generated nystagmus. The 2 main outcomes of his experiments were the generated nystagmus is always directed parallel to the plane of the stimulated canal. That is the Evalt's first law. That is what we do during the positional test. The second is that the generated nystagmus is stronger when the endolymph moves towards the ampulla, that is the ampulopetrocupular deflection in case of horizontal semicircular canal. That is the Evalt's second law. And away from the ampulla, that is the ampulofugal deflection in case of vertical semicircular canals. That is the posterior and semicircular anterior canals. That is the Evalt's third law. That is what we observe to lateralize and localize the involved semicircular canal. So what is done to treat BPPV? The non-ampullary arm of the semicircular canal have a utricular exit through which the otoconia inappropriately move out of the utricle into the semicircular canal. So during repositioning, the head along with the body of the patient are sequentially oriented in a manner that the otoconia are moved out from semicircular canal under the gravitational pull towards the utricular exit. The location is deciphered according to the oculomotor patterns generated during the diagnostic positional test. In cupulolithiasis, the inertial forces are generated either by head shaking or by mastoid oscillation to disengage the otoconia adherent to the cupula, or by making use of gravity during the forced prolonged positioning, the otoconia are facilitated to drop down from the cupula. So now we come to actually some cases here. This is BPPV of the posterior semicircular canal, canalolithiasis. For more videos, you can see to my channel, which is here. This is a lady of around 38 years old, came with history of vertigo for past 7 days. The right disc sulpi shows a upbeating right torsional nystagmus. The direction of torsion decides the canal, and it is the right posterior semicircular canal BPPV. So she was treated with the Apple maneuver. The right disc sulpi position was maintained for around 1 minute, after which the head was inclined to opposite side, again maintained for 1 minute, after which the left lateral recumbent, that is the non-involved lateral recumbent position, for 1 minute was done. And this was again maintained for 1 minute, after which she was uprighted, completing 1 Apple maneuver. When you do Apple maneuver, you can't leave the patient. You have to call him and see the disappearance of vertigo during the repeat or the verifying positional test. So a verifying right disc sulpi test done post Apple maneuver did not elicit any nystagmus, and she did not complain of vertigo as well. So no investigations, no drug treatment, only observing the oculomotor patterns during the positional testing, and the patient got cured. The horizontal semicircular canal BPPV is slightly dicey, where we do a test which is called the supine roll test or the Paganini-Macchio maneuver. It elicits a horizontal bidirectional nystagmus, that is a lateral head roll to right as well as to the left. There is a nystagmus which is horizontal, and this nystagmus could be either geotropic, where the quick component beats towards the lowermost ear, or it could be apogeotropic, where the quick component beats away from the lowermost ear. So its lateralization and localization is slightly difficult compared to the posterior canal BPPV. Yet this type of BPPV is not very uncommon. It forms 10% of the all cases of BPPV. So what is geotropic? This is the lateral head roll to right shown in this diagram. The geotropic variant means you just see his pupils. The quick component beats towards the lowermost right ear and the slow component is away from it. I am playing it once again. The quick towards the lowermost ear and the slow component is away from the lowermost ear. So it is important that in the geotropic variant, the involved side, that is the lateralization, is one with the stronger positioning nystagmus on the supine roll test. While in the apogeotropic variant, I am again showing this, the quick component is beating away from the lowermost right ear. This is the slow and this is the quick component. Again, I am showing slow and this is the quick component. It is important to remember that in the apogeotropic variant, the involved side is one with the weaker positioning nystagmus during the supine roll test. With this anatomy and the positional test, we take up a case, a 19-year-old patient who had come with history of vertigo for past 4 days. The supine roll test, his head is landing on a pillow which is 4 inch thick, so it antiflexes the cervical spine. On lateral head roll to right, it elicits a geotropic nystagmus with quick component beating towards the lowermost right ear on right lateral head roll. While on lateral head roll to the left, it also elicits a similar nystagmus, geotropic quick component beating towards the lowermost left ear. And if we compare the intensity, the lateral head roll to the left elicits a stronger nystagmus, so that we had earlier seen that this is a case of left long non-ampullary arm horizontal semicircular canalolithiasis. So geotropic variant. So it has to be treated with Guffoni manner. From the short sitting, the patient is positioned to the right lateral recumbent wall side and is maintained in this position for 1-2 minutes, after which the head is inclined downwards in the yaw axis and maintained for another 2 minutes, and then the patient is uprighted, completing one Guffoni maneuver. Again, 1 hour later, a verifying supine roll test is done to look for the elimination of nystagmus, and on lateral head roll to left as well as to the right, it did not elicit any nystagmus and the patient was free of vertigo. Again, no drug was given, no investigation was done, and this is almost 4 years. He did not report to me back for any other symptoms. So how it works, this is the otoconia in the long posterior arm of the non-ampullary arm of the left horizontal semicircular canal. As the patient is taken to the right lateral recumbent position, that is the non-involved side, the horizontal canal becomes vertical and the otoconia moves towards the vestibulum. And as the head is inclined downwards to around 45 degrees or more in the yaw axis, it enters into the utricle, thus clearing the canal of any otoconial debris and curing the patient. BPPV of the horizontal semicircular canal, the apogeotropic variant, is slightly difficult to treat because it is because of cupulolithiasis. This is a lady with 15 days history of vertigo. On positional in character, on lateral head roll to right, she elicits a apogeotropic nystagmus. The quick component is beating away from the lowermost right ear. And this is a pretty long nystagmus of 3 minutes duration. I am scrolling it to around 3 minutes and 22 seconds. It is still present. And on lateral head roll to left, there is again a apogeotropic nystagmus. The quick component is beating away from the lowermost left ear. However, on the left side, the intensity of the nystagmus is less compared to that on the right side, and that lateralizes the diseased canal to be the left. So it is a case of left-sided horizontal semicircular cupulolithiasis. This is one of those fortunated patients who responded to immediately to the head shaking maneuver. In short sitting, her head was antiflexed around 30 degrees and was shaken side to side in 30-degree excursions for around 30 seconds. The bucket you see in this is because we are causing a severe vestibular stimulation and these patients sometimes vomit. So she was taken up for a verifying supine rule test 1 hour later. And at that time, the lateral head roll to right did not elicit any nystagmus, absolutely static eyes, no nystagmus, no associated vertigo. And lateral head roll to the left also did not elicit any nystagmus or vertigo. So without any treatment, without any drug, or without any investigations, just observing the oculomotor patterns and lateralizing the canal and pathology, I could reach to a diagnosis and treatment, and the patient did not return. It is almost 4 years now. Horizontal semicircular canal BPPV due to pupillithiasis can be due to the otoconal debris attaching either on the utricular side or the canal side of the cupula. This was certainly on the utricular side because as they got disengaged due to the inertial forces generated during the head shaking, they dispersed into the utricular matrix and there was immediate relief. So this is a case of the cup U variant, that is the cup U variant of pupillithiasis. Matlab the otoconia are attached to the, are adherent to the utricular side of the cupula. Anterior semicircular canal BPPV is the least frequent of BPPVs. Some of the neurologists around the world, they even doubt its entity. However, it is important to recognize and treat. This is a young man of around 45 years, came with history of vertigo for past 3 days. This is, you can see in his right eye, the vessels. There is a downbeat nystagmus, and which is left torsional. So it localizes, this is called the side-lying test, which is equivalent to the Dix-Hallpike testing. It elicits a downbeating left torsional nystagmus indicating left anterior semicircular canal BPPV. So he was treated with the maneuver which is known as the Iacoviano maneuver or the deep head hanging maneuver. From the long sitting, his head was positioned to maximum enhanced head hanging position, maximum extension possible. And this position maintained for around 1 minute, after which the chin to chest position was done like this, so that the vertex of the head points towards the sky. And this position is maintained for another 1 minute. And after which he is uprighted to long sitting position again. 1 hour later, he is taken up for a test again. This is how the otoconia move. You can see in the right here, it is the position in the periambular portion of the superior or the anterior semicircular canal. As the patient is taken to the Iacoviano position 2, the otoconia move away from the ampulla. In the position 3, that is chin to chest position, it moves towards the common crus. And as the patient is again uprighted, it moves into the utricle, repositioned back, and there is no vertigo. There should not be any. So this is a verifying side-lying test done in this patient 1 hour later, and there is no nystagmus and no concomitant vertigo. So these patients should be followed up telephonically at least for at least 1 month, because in anterior semicircular canal BPPV, if there is no response to the positioning therapy, you need to take patient for MRI brain and possibly a screen of this CV junction to look for any central cause of the downbeating nystagmus. BPPV of the posterior semicircular canal pupillithiasis is the one of the most rare variants which does not respond to repositioning maneuvers. So this is tested by the half Hallpike position, which often elicits a prolonged upbeating ipsitorsional nystagmus. This is the Dix-Hallpike position, in which from the long sitting, the head is positioned to 120 degrees at the head end of the examination table, not suitable for evaluating the posterior pupillithiasis because of the variations in the shape of the posterior cupula. The posterior cupula is more orthogonal in the half Hallpike position, in which from the upright sitting, the head is positioned to around 60 degrees. And if a pillow of around 4 to 5 inch thickness is placed at the head end of the examination table, like this, it will eventually make a half alpine position to the right shown in this slide without taking the help of the hands as shown here. So this is a 61-year-old male patient, came with a history of vertigo for past 15 days. The half alpine position, look that his head is landing on a pillow which is 4 inch thick. Elicits after a latency of 13 seconds, a upbeating right torsional nystagmus. So this was a long duration nystagmus. I am scrolling it to around 1 minute and 54 seconds to show that it is still present. At 2 minutes, I asked this patient to take the left lateral recumbent position with nose down. This is called inversion test. This has to be positive in the adherent type of pupillolithiasis. And if it is positive, both components, they reverse polarity. The upbeating nystagmus now has become downbeating, and the torsional component has also reversed from right torsional to the left torsional. That left torsional component is seen best in the right eye of the patient, where the upper poles of the eyes are seen to be moving towards the patient's left ear. So this is a pupillolithiasis of the posterior semicircular canal. Don't try to do any maneuvers. It won't respond. Usually such cases, they respond within a period of 30 days. You can give vertigo suppressant drugs, or sometimes you treat them with the Brent-Daroff exercises, which I am showing here. This is the instructive video for the patient. 30 seconds, the patient is kept in this position. After 30 seconds, the patient is made to sit. Then again, the same procedure is repeated on the other side.
तो अपने को इनकी राइट साइड में इनकी लेफ्ट साइड में निकालना, ये पोजीशन रहेगी आधा मिनट.
This stands to be done on 10 times on each side for at least 30 days. And
मैं आपको समझ के पोजीशन ऐसे कर, मैं उठा ले रहा हूँ, खुद भी नहीं है छाती को, तो बैठने के बाद गर्दन की पोजीशन आपने, ये मैंने आपको 2 सेट इधर और 2 सेट इधर बताया. आपको घर पे करना है 10 सेट इधर और 10 सेट इधर. हर एक की जो पोजीशन टाइम है वो 3 सेकंड है, और एक बार पोजीशन देने के बाद बैठाओगे तो 30 सेकंड है. इसका इधर 30 सेकंड इधर, 30 सेकंड बैठा, 30 सेकंड 10 बार इधर, 10 बार इधर. ठीक है, कम से कम 1 मिनट तक कराऊंगा सब्जेक्ट.
so the by Cawthorne-Cooksey exercises, we are coming towards the last part of our talk. The bipedal walking is inherently unstable. We require us to move our center of mass in front before every step. So Cawthorne-Cooksey exercises, they improve the vestibular hypofunction by reinforcing the vestibulo-ocular, vestibulospinal, and vestibulocholic reflexes. So this is a video which I have made, which I give to my patients instead of tear away sheets.
पैन की तरफ देखिए और गर्दन को इधर, नजर आपकी पैन पे ही देगी, वापस इधर, फिर इधर. पहले धीरे धीरे किया आपने, फिर थोड़ा तेज करना शुरू किया, तेज करेंगे. नजर आपकी पैन पे गड़ी हुई. ये लगभग 20 बार राइट पे और 20 बार लेफ्ट पे. ये हो गई एक्सरसाइज नंबर 3. दूसरी एक्सरसाइज है, इसके टिप की तरफ देखते रहिए. इसको नाक के पास लाए, इधर देखा, 1 2 3, ऐसे 20 बार आपको करना है. ठीक है. तीसरी एक्सरसाइज है, आपको इसको जहां ये जा रहा है वहीं आप इसको सिर को ले जाए. इस टिप की तरफ देखते रहेंगे, ये ऐसे भी आप क्लास करेंगे और इस टिप की तरफ देखते रहो, मतलब ऊपर ले जाओ और नीचे ले जाओ, टिप की तरफ देखते रहो.
We are enforcing the vestibulo-ocular reflexes in both the horizontal as well as the vertical plane, as well as we are doing the VR suppression.
ऊपर नीचे, ऊपर नीचे, ऊपर नीचे, ऊपर नीचे, ऊपर नीचे. पूरा घूमे बैठे, अब अपोजिट घूमे खड़े हो, अपोजिट.
Such rotations may be done several times. This is again we are doing the vestibulospinal reflexes. You can take a ball or even a pen, rotate it right and left multiple times. Then you can ask him to stand on one leg, keep the one leg up, foot above the ground. First, judge the patient. You cannot ask him to lift more.
ऐसे करेगा 20 बार इस पे पड़ा होगा, 30 बार. अब एक लाइन पे करके दिखाइए, फिर 10 कदम चलेंगे, एक पाव के आगे. चलिए 1 2 3 4 5 6 7 8 9 10. पीछे कौन जाइए, वापस ऐसे करेंगे. और उल्टा चलिए, ऐसा उल्टा चलिए. वेरी गुड, वेरी गुड. इसका रखिए, ऐसे करेंगे हम 10 बार आगे, 10 बार पीछे. एक और लेके इस तरह से ऊपर और नीचे, ऊपर आंखों के ऊपर चले जाओ.
Usually it should be taken above your levels of the eyes so that the vestibulo-ocular reflexes as well as the VO are done at the same time. And if the vestibulospinal reflexes are to be added, then on standing as well as on walking.
ऐसे कई बार 20 बार ऐसे करना है, 20 बार बैठ के करना है, 20 बार खड़े होकर करना है, 20 बार. तो एक बार पीछे, एक बार आगे, एक बार पीछे, दिस इज कॉल्ड शोल्डर स्ट्रमिंग. एक बार पीछे, एक बार आगे, एक बार पीछे, एक बार आगे, पीछे एक बार आगे, एक बार पीछे, एक बार आगे. ऐसे करीबन 20 बार आगे, 20 बार पीछे करना है.
So I feel that if you give them this video, that they will do it better than just giving away the tear away sheets. So finally, every human step is nearly to fall, but for a complex full body coordination mediated by the vestibular system through vestibulo-ocular, vestibulospinal, and vestibulo-ocular reflexes, vision and proprioception. With this, I end my presentation here. Thank you very much.
Dwarka. Okay, thank you very much, Dr. Vats. It's an exhaustive presentation, much of which is not much known to the neurosurgeons. In fact, so we had a great learning exercise. There are a few questions here on the chat box, and then we'll have some more questions chatting. I don't know whether it's gone. Dwarka, can you see that question?
Yeah, Dr. Deepak.
Yeah, it's visible.
Can clinical examination localize anatomical localization of the problem of the structure causing it?
Yes, actually you can. You can tell whether it's a central lesion. And Dr. Vats has already demonstrated about how to evaluate each of the semicircular canals when it's a BPPV. Of course, most even ENT physicians are not very well versed with this type of information which Dr. Vats has imparted is actually exemplary, I must say. So yes, it is very much possible to differentiate between them, and that is what is the importance and beauty of clinical examination.
And the second question was to how to clinically differentiate between central and peripheral vertigo, and any tips on how to question the patient on this.
I think I have already shown that in my presentation. Dr. Vats, would you like to show some light on it?
Here, sir, the nystagmus characteristics are very important. We know that a gaze-evoked nystagmus. You told about the vertical nystagmus. A vertical nystagmus is almost always a central cause, unless and until you do a positional test and you find a upbeating torsional nystagmus. Here it is a torsional component as well as a vertical component, but it is positional. The thing is that if you get a downbeat nystagmus, which is spontaneous, it is for all purposes a central nystagmus. A gaze-evoked nystagmus, because the gaze-holding mechanisms are in the brainstem. Whether it is a vertical gaze-evoked nystagmus or a horizontal gaze-evoked nystagmus, the medial vestibular nucleus and nucleus prepositus hypoglossi, they are the gaze-holding structure for the horizontal gaze. So if you get a gaze-evoked nystagmus, it is almost a central nystagmus. Then again, the peripheral nystagmus is unidirectional. It is mixed torsional and horizontal, and it is always, it can never change its direction, and it follows the Alexander law. That its amplitude increases in the direction of the fast phase of the nystagmus. The central nystagmus, it can be multi-directional. For example, a periodic alternating nystagmus, it can change directions. So this is one of these. It can be disconjugate. The nystagmus can be disconjugate. So the nystagmus is the most objective way to differentiate between the central and positional vertigo. Otherwise, the severity of the vertigo is more severe, mostly in cases of peripheral vertigo. In central vertigo, in Wallenberg syndrome, for example, you can have a severe vertigo as well as retropulsion. But there you have a severe retropulsion in addition to vertigo. And if you ask carefully, it is the retropulsion which is important. Again, the signs like intranuclear ophthalmoplegia and skewed avation, they are almost invariably pathognomic of a central vertigo. So look for these associated oculomotor signs despite nystagmus. Historically, it may not be very possible to differentiate between the two. The central vertigo is usually not very severe compared to the peripheral vertigo.
Also, when you want to examine for nystagmus, latency and fatigability is seen more in peripheral causes as compared to central causes.
Yeah.
Yeah.
So I had a question to Professor Rajshekhar regarding the improvement of tinnitus and vertigo after stereotactic radiosurgery for small vestibular schwannomas. So what has been your experience with those?
Sorry, I didn't get you, Dwarak. You said microsurgery versus radiosurgery, is it? For
improvement in tinnitus and vertigo.
Pardon?
For improvement in tinnitus and vertigo. So,
yes.
What has been your experience with SRS for those?
Yeah. So tinnitus is can be a very difficult symptom to treat, whether you use microsurgery or radiosurgery. And I always warn my patients that don't expect that the tinnitus will go away following any therapy, be it radiosurgery or microsurgery. And I still remember a patient with a 4-centimeter vestibular schwannoma, which we excised. Can you imagine a 4-centimeter vestibular schwannoma with no hearing? but she comes back after a year and the only problem is tinnitus on the side, on the operated side. Now, where is that coming from? Obviously, it's some central mechanism that's, causing the tinnitus or psychogenic, whatever you want to call it. So tinnitus is a very difficult problem, and I have not studied it carefully or looked at it, but both tinnitus and vertigo, dizziness, seem to persist even after treatment, like it was shown in that paper, in up to 60% of patients. Of course, it's severe only in about 20 to 30%. And the risk factors were also mentioned in that article. I don't have any personal experience or data beyond that.
Paritosh? I think you're muted. So there's one more question which Dr. Jha is asked. Why vertigo in many patients improves after Philadelphia cervical collar? Light on that.
Again, I didn't get that. Why is vertigo?
Many patients improve after Philadelphia cervical collar.
It's a psychological improvement.
Yes, I also agree with Sumit that I do not believe in this business of cervical vertigo, and I don't accept it as a pathology or as a diagnosis. And I think we should take that with a pinch of salt. Just because they have improved with a cervical collar doesn't necessarily mean. See, remember, when you're restricting neck movements, you're also restricting head movements.
Exactly.
See that, so you can't just say that only the neck movements are, restricted with a collar. You're also restricted. So, it means if you read that article is very clear, very nicely explained the controversial nature of this entity called cervical vertigo.
Totally agree with Professor Rajshekhar. The head motion intolerance is common to every form of vertigo, particularly so in case of BPPV, but in all cases of vertigo, whether central or peripheral. So when you put a head Philadelphia collar, your neck is immobilized. So your head will not move. So indirectly, you are immobilizing your head, and that is leading to alleviation of symptoms.
And also a feeling that something is being done for you by somebody.
Yeah,
that psychological support is always there.
Yeah.
Sir, I have a question to Dr. Rajshekhar. Are there any types of vertigo which are more amenable for MVD for severe vertigo, which is not getting better with symptoms? Any specific types? And the second question is what is the current role for vestibular neurectomy for Meniere's disease, which used to be popular at one point of time?
So let me start with the second question. Actually, today morning, my wife, who some of you may know is an ENT surgeon, she said you're going to get that question on vestibular neurectomy for Meniere's disease. And just as she predicted, you are asking me that question. No personal experience again. I don't know whether, I've been referred a few cases, but I hesitate to do that because I don't know whether I'll make them, any better. Most probably I'll make them worse. So I don't know whether it's still being practiced. I think ENT surgeons still do it. Some of them may be doing it, but I have no experience with it. And with respect to MVD, what I read in that meta-analysis was if the patient comes to you with both tinnitus and vertigo, 62% reported subjective improvement. So you're more likely to help a patient with MVD if there is both tinnitus and vertigo. Vertigo alone, the success rate was 30-odd%. But remember, again, there is a lot of a subjective component to this because vertigo is a subjective symptom. So unless you have formal, objective tests, as Dr. Vats has showed very nicely, so beautifully demonstrated, we have objective evidence that we have helped the patient. It's very difficult to support an invasive, quite a major surgery. MVD is major surgery and complication rates were 11%. So I would hesitate to recommend MVD for anybody unless everything has been tried, patient is desperate. Even then, I would be very, I have not operated on such a patient, to be very frank. I recently was referred a patient from Delhi, actually. And I said, and they were recommended MBD, and that lady, she's suffering from vertigo for many years. I said, I won't. So she asked for a second or a third opinion. I said, no, I wouldn't recommend.
So Dr. Sumit and Dr. Vats, in your practice, do you refer patients for surgery for vertigo? When do you refer?
Not unless they have a acoustic shunt.
Okay.
Practically,
I have a question.
I do agree with Sumit. Unless and until they have schwannoma or any other CP ankle pathology, we don't refer. The case of microvascular decompression in case of vestibular paroxysmia is controversial because the many loops are incidental, and again the distance of the root entry zone from the loop is very important because the first 10 millimeter of the root entry zone has a transitional myelin. And if you have response to this treatment with carbamazepine or glycosapide, it proves the diagnosis in patients who has stereotypic attacks. Many of my patients in my initial years of practice, in whom I suspected vestibular paroxysmia, they came up with BPPV. The first time the nystagmus was not elicited. Around 3 to 4 days later, when I examined and did a repeat positional test, it was found. So again, this is a dicey diagnosis. The microvascular decompression is done in and out for trigeminal neuralgia. For the hemifacial spasm, it is not done, at least in my place. And for the vertigo or the vestibular paroxysmia, I have hardly heard in our country.
So, Dr. Vats, you showed very extensive treatment for capillolithiasis and BPPV and other things. How frequently is it practiced around the country? I mean, this is as extensive as I've ever heard in my life. So, are there many practitioners who practice this kind of a thing, or you are one of the kind?
No,
this is his passion. I think it's his passion which speaks for itself.
Yes, this is my
This
passion.
is undoubtedly the best exhibition of any type of vestibular functions which I've ever seen in my life, and believe me, I've seen a lot.
Dr. Paritosh, it's my passion because my wife suffered from BPPV during my DM days, and she just questioned that what type of training you are taking that you cannot treat my So I have not taken any formal training after doing DM in 2005 at the age of 42. So I started practicing this by seeing the handouts. There was a neurology clinics published in 2000, which had a chapter by one from Georgia. Then I started taking all these positional tests, and I have been attending all the neurology courses by Professor Sudhir Kothari by the Fine, and everywhere it is in India I go or abroad. So that is how I learned, and my patients are my laboratory. So all my publications are on this BPPV only.
It's an exemplary exhibition, I must say.
Yeah, so I also want to congratulate you on your demonstration of management of vertigo. But I just want to clarify that Paritosh, ENT surgeons do practice similar kind of maneuvers. My wife, being an ENT surgeon, actually is published on BPPV and all about 20 years ago. She is no longer into otology, she's into rhinology now. But there are ENT surgeons who are specialized in this. And
yes,
they do kind of, I don't know to the same extent that Dr. Vats is doing, because he's not only doing it, but he's also documenting it. That is the beauty of his practice. He's documenting it well, documenting it well to teach others. And I think that is the uniqueness of his practice. So there may be people doing it. So thank you, Dr. Vats, for an excellent presentation.
Thank you, sir, for your kind words.
I have another question to Dr. Sumit and Dr. Vats. Regarding the drugs you use for treating vertigo, I mean, how far and how fast can you escalate the doses, and when do you think of adding any second tablets and all that for the management? And what has been your personal experience?
For which disorder? I would ask you not for.
I mean, when you start off beta histine or medicines like that for vertigo as medical management, how fast do you escalate them, And till when do you say, okay, this drug is not
See,
going to work?
it all depends. Suppose we are treating a case of vestibular migraine. It depends on the specific diagnosis. We are not talking about the vertigo suppressant drugs. We are treating about the specific drugs. You have a very obese lady who comes to you with episodes of vertigo, some headache, some cervical pain also, but they are occurring concurrently and there is associated vomiting, photo and sonophobia. Naturally, I won't give her divalproex or the flunarizine because it will cause her weight gain. I will choose a drug like topiramate, which is weight losing and it has to be uptitrated very slowly because it causes the acral paresthesia and sometimes psychomotor retardation, and even sometimes it can cause severe glaucoma. So it is uptitrated over a period of few weeks. In Meniere's disease, I do use beta-histine, and I am strongly advocates using it in conjunction with MAO inhibitors. Usually, MAO inhibitors are not used by routine ENT also because most of the beta-histine is metabolized. It undergoes a first-pass metabolism through the MAO. So if you add the MAO inhibitors to beta-histine, you will get a better blood levels. And one of the studies in earlier used to say that you give 48 milligram of the beta-histine 3 times a week. I used to titrate it over a period of 3 to 4 weeks. But now my practice has changed after a paper of Michael Stroop, which has been retracted. I say retracted for some other reasons, but he still uses it. I have a mail on my email box about this. So he uses the low doses of beta-histine, say 24 milligram. I use the mouth dispersing tablets for this, along with either selgiline or rasagiline. And I found that in at least 10 of my patients for past 2 years, they have significant reduction in the number of vertigo attacks which they were having at the baseline. So the first thing is that now recently I don't use up titration. I use with 25 milligram of the beta-histine, and I use either along with rasagiline or selgiline, and I ask them to come for around 2 months, and then I see how many attacks they had, and accordingly I titrate up to maximum 48 milligram. The other things are like corticosteroids. You give an acute vestibular neuritis for immediate relief. The long-term relief is not documented in terms of assessment of the vestibular functions. So you give, in my practice, because these patients are severely vomiting, I admit them, I give 1-methylprednisolone injection, give some antiemetics, and then give a tapering dose of 2 to 3 weeks of steroids. So that is I do for the symptomatic relief of acute vestibular neuritis as acute vestibular neuritis. So other things are the vestibular paroxysmia, which is a entity in which you give carbamazepine or lacosamide, uptitrating the dose. You start with 50 milligram for 5 days, then 100 milligram for another 5 days, then up to 150 milligram you give for 2 months, and then you see the response. And if the response, it is likely to be a neurovascular cross-compensation syndrome of the vestibular paroxysmia. There are no tests to document this.
I would like to add that I think I stop beta-histine and labyrinthine sedatives more often than I prescribe it, because I've seen people taking months and months of beta-histine and other labyrinthine sedatives for a single episode of BPP.
Yeah.
The detailed evaluation is not done. Exercises are not advised. They are just written. The moment somebody says chakkar, the same moment beta-histine or cenarazine would come into play. So
Yeah,
I actually stop more than I actually prescribe. And as he rightly told, the cause is the direction for how long to give and which drug to give and with which combination to try.
Same question, Dr. Rajshekhar sir. And post-operatively, if the patients complain of vertigo, and what is your preference for labyrinthine sedatives, and how long do you use?
To tell you the truth, I would actually ask our ENT colleagues to evaluate the patient and decide because like I kept mentioning during my talk, I don't think we are responsible for, they are responsible. It's not a post-operative complication, or it's not a post-operative side effect. It's got a completely different etiology or cause, and we need to let the experts handle it. So usually it means, because if the patient has got a cervical spine surgery or even a craniotomy, they won't be suitable for any kind of maneuvers, and they may start them on Vertin and stuff like that. But later on, after the patient is okay from our side, discharged, we would pass them on to the ENT colleagues. So this is what I would suggest, rather than us trying to handle it. We are not the experts in vertigo. I have no any kind of shame in accepting that we are not the experts in vertigo. We let either the neurologists or the ENT colleagues handle it, and I think they will do a better job than we can do.
Yeah, bro. I think nothing is there.
So, would you like to give the vote of thanks, Paritosh?
Hey.
Okay, ठीक. I think Paritosh is busy in his cath lab. So
No, I'm not busy. I'm just.
So then you give the
boss. Hey, you boss. Come.
Huh? Chalo, ठीक है. On behalf of the NSI, I thank the esteemed faculty, Dr. Sumit Singh, Dr. Vats, and Dr. Rajshekhar for the wonderful presentation. It's a great experience learning, listening to all the three of you, and we would like to thank, on behalf of my co-chair, Dr. Paritosh Pandey, and Dr. Debashish, who unfortunately could not join us. A huge thank to all the three of you. And for all the listeners, this video will be available on the NSI website. It can be downloaded and seen. And more often than not, a lot of people do see these videos, and we've had very pleasant feedback from many of the users who see this video at a more convenient time. Thank you all.
Thank you very much.
Thank you. Have a good
Great learning. Thank you very much. Thanks.